session, please welcome on stage Dr. Chris Bates, Director of Research and Analytics from TPP.
Yes, it's a great pleasure to be able to introduce this session, eagerly awaited session, backed by popular demand from last year, so we can get an update on the current state of generative AI in healthcare and how it's been used around the world. We have a fantastic chair and a brilliant panel here ready for you, and they're raring to go, and we're all looking forward to what they've got to say. To briefly set the scene, generative AI is the class of AI technology that creates new content from real data. So it creates images, videos, and writes text, for example. That same technology gives it groundbreaking capabilities for pattern recognition and to understand the context almost that it's working in, so to understand images and almost to understand text, and that gives it great potential. If you're very new to it, probably the best example of generative AI is ChatGPT, which is one of what we would call a class of new large language models. I'm sure most people here have heard of ChatGPT. I'm sure some people have played with it. Some people maybe have used it to tweak a tricky sentence in an email or two. And some people may have thought or indeed use it in a professional capacity. Generative AI is also the technology that forms a key component of voice assistants, such as Alexa and Siri, that we all now use routinely. So it's a transformative force in AI. It's making a massive difference in different areas of our lives, even if we don't quite realize it. And this session really couldn't come at a better time because there's been an explosion of interest in how generative AI can be used in healthcare, from drug discovery to clinical decision support, from automated documentation using voice recognition, to symptom checking, triage systems, to significantly enhancing radiology workflows. The possibilities seem quite endless. We've seen these possibilities directly in our own work at TPP. We've seen how language models can really start to unlock the gold mine of data that's in clinical notes and in patient documentation in that clinical narrative. It understands sentence structure very well. It works with complex clinical terminologies. It understands the different ways that people record signs and symptoms and diagnoses. It understands the plethora of spelling mistakes we often see in these things. It's giving really new, huge capabilities. And what I think from our point of view, what we've seen is it's the ability to move cutting-edge analytics from the gold standard kind of research data level to the data we collect routinely at the front line of clinical care where it's needed the very most. And of course, this is all underpinned by very sophisticated mathematics and developments in computer science. But nobody in this room will ever be judged for the sophistication of the technology they deploy. We'll be judged, that's not the metric. The success metric will be outcomes. What does it mean to patients? What does it mean to clinicians? So from our own examples, we've seen that if we use this technology, the predictive power of our suite of AI algorithms for early cancer diagnosis is significantly enhanced. What that means is better staging, better prognosis, and better survival rates. We've seen at a national level, working with public health teams, that if we use this technology, we can do outbreak detection at a huge scale very, very accurately, putting real-time information at the fingertips of public health teams so they can control breakthrough infections and get responses together as quickly as possible. Slightly differently, but we were just talking about this earlier, we've seen how this technology can reduce non-attendance rates in clinics. In our own work, it's reduced it by 30% just by having algorithms which alert teams of management teams and clinical teams to the people who are most likely not to attend that appointment, which of course means we can free up more resource at a time when sustainability is absolutely key to healthcare. But at the same time as this explosion of interest in the field, generative AI comes entwined with social and ethical concerns. How do we ensure that the technology is accurate enough for use in medicine? How do we ensure that it doesn't produce bias against certain groups of patients? How do we ensure that as we introduce more digital technology, we don't increase health inequalities inadvertently? How do we balance innovation and regulation? How do we balance patient privacy and research? So it's a very complex landscape for us to navigate. And I, for one, am glad that that's not my job this morning. Instead, that's the job of your fantastic chair, Sara Siegel. Sara is head of global health at Deloitte. She plays a pivotal role in shaping the future of healthcare around the world. She's got vast experience in innovation and healthcare strategy, and relevant for today, the use of AI to start to tackle some of the significant and diverse problems we all have in our healthcare systems, things like workforce shortages, operational efficiencies, population health management. So I'll let Sara set the scene further and introduce the panelists, but for now, can we give a really warm IHF welcome to your chair, Sara Siegel.
Thank you, Chris. I needn't introduce myself because you've already done that really beautifully. I appreciate that. Welcome, everyone. I think this morning you're in for a real treat. If some of you were here last year, we did a similar panel on generative AI in health. It was myself and Dr. Schlosser and some other panelists. And we've been invited back, which means we didn't do a terrible job, but it also means we're feeling the pressure. But I think you're going to enjoy this morning's session. We have 3 amazing panelists. They're each going to speak, and then we'll do some Q&A. The first panelist is Dr. Rafael Correia Barão, an ophthalmologist at Unidade Local de Saúde, Santa Maria in Portugal. And he is going to speak to us about the SEER project, which is about use of AI in ophthalmology. So a real patient-specific clinical example. Then we're going to hear from Professor Aymeric Lim, who's the Chief Executive Officer at the National University Hospital Singapore. And he is going to talk to us about a really big opportunity area, which is using AI to transform hospital operations. And then we're going to hear from Dr. Michael Schlosser, who's Senior Vice President of Care Transformation and Innovation at HCA International. And Michael is going to talk to us about developing scaled implementations for transformative AI solutions in healthcare. So we're kind of going to go from the small and specific at the patient level to the big and scale at the system level. And then, of course, we're going to do some Q&A. And I would encourage you all to, I'm sure you've downloaded the app by now, but open the app, look for Plenary 3, and if you put questions in, I will perhaps ask them to our panelists. But before we hear from our panelists, I will just say a few words as an opening. Now, I think everyone in this audience will know a bit about generative AI, but we'll start from the beginning and we'll move very quickly. Slides, please. Great. So I think the big question posed of us this year was what's changed? We were here last year talking about this. It was very exciting. There was a lot of questions. We've seen things like, a huge bump and then a dip in shares of companies like NVIDIA. And I think people are asking now questions like, is it a blip? Is it really going to be this life-changing? And that's the sort of thing that I'd like to get to today. But just in summary, there we go. We're just going to talk a little bit about kind of what it is. I think if you're in the room, you know what it is. And the big change that we saw from AI to generative AI is that it's not just summarizing and presenting things that we already knew. It has that ability to transform and put something new in front of us. And so that something new comes from, obviously, the data that it's looking at. But it is that flip which makes it so powerful. And as we all know, it can do this using text, using video, using audio, using image, et cetera. And it looks simple when we type things into ChatGPT, but it's not. We see the top layer, we see the output, and because it has a simple language prompt, it seems simple, but it is layers upon layers. So, first you have, I already mentioned NVIDIA, but you have the GPUs, you have the big compute power. And we've also done panels this week on sustainability. One of the big questions here is that all of this generative AI compute power is creating more environmental challenge for us. It's using energy, it's using massive cooling, and it's also taking compute power away from other things. So as usual, when you poke the balloon, the air has to go somewhere. So we are solving one problem but creating another. But on top of that compute power sits big data layers, models on top of that, fine-tuning and prediction on top of that, and then we get what we see. So it looks simple, but it is really complex. And a lot of the risks that we spoke about last year, still exist. Hallucination, still a thing. Bias, this is really endemic. We had an amazing women's panel, was it yesterday? Day before yesterday, where we talked about gender bias in AI. And because of the gender data gap, this is one of the bias challenges that's going to be really hard to solve because we just can't feed the LLMs with enough data to equalize. So we have to think about other things and other ways to come across these. It's really important that we talk about these risks and the problems with AI up front because we don't want it to be something which isn't effective and impactful. So I think the honest conversation and the open book dialogue is really important when it comes to the risks of AI. And here we just talk a little bit about go first, go second, like save it till later. One of the things we've developed at Deloitte to help with this is something that we call our trustworthy AI framework. And we have these 7 principles. They seem sort of blatantly obvious, but the good thing here is that they flow through to really tactical things that you can do, like keeping a human in the loop, extensive pen testing, audit, et cetera, to make sure that when you're working with AI, you are creating a trustworthy AI source for whatever you're doing. Now, these are all general AI principles and tools, but we all work in healthcare. So let's get specific. There are so many challenges in healthcare, and we'll talk about how AI can help to solve some of them. I've thrown 4 major ones on this slide. We could all list many, many more, but in my travels, our challenges with workforce, our challenges with cost, our challenges with clinical quality, et cetera, the never-ending demand curve, I really believe that technology is at the forefront of this. I'm actually based in the UK, same as Chris, and just this morning our Prime Minister was speaking about his 10-year plan for our National Health Service. And he sees 3 big shifts, which are 3 shifts which we've actually been talking about for a long time, but I support them. And one of the shifts that he's speaking about is analog to digital. And I watched some of his Q&A with reporters, and they were asking about all of the operational challenges in healthcare. Why is the A&E wait so long? Why is the time to wait for elective surgery so long? And for most of his answers, he had a technology lens, which I've honestly never heard a prime minister have before. And it's not just big electronic medical records technologies. He's talking about nimble software tools like generative AI. So I personally am an optimist. Many of you who know me will know that. And I think there is a lot of hope for the future in healthcare with this and other tools to solve some of these really endemic problems. So where can you use generative AI in healthcare? Literally everywhere. It can accelerate things, get things done faster. If you think about things that used to take a long time at the front end, it can generate an answer quickly. It can create new things. If you think about how long doctors used to take to summarize notes for patients, it can make things personalized. I saw a great demo from a tech vendor that had done something with a very complicated diagnosis. It had put it into simple language, and then it had translated into the mother tongue for the patient's family to read and understand, and then it had a Q&A chatbot at the bottom so the family could actually interact with it. And that's just, that's no extra work for the clinician or the hospital, but that makes something complicated and difficult easy to understand, and that can bring, comfort and support in a very challenging time. It can also simulate. I think we'll hear from the experts today, but we have a lot of clients who are looking at things like the setup of their A&E or their ER, depending on where you're from, and they're saying, if we put more nurses over there, or if we triage like this, or if we put an app like this, what would that do to flow? Would that make it faster? Would that make it different? You can build a digital twin of anything, of the road construction around your facility, of the structure or the staffing of your A&E or the flow of your OR, and you can test these theories without having to put physical infrastructure changes in place, which is a lot cheaper and will help you plan things. So there's just so much that you can do. And then just thinking about, the flow of healthcare, again, there's AI applications in the entire value chain, which is the top line here, and then in all of the functional areas. And one of the things I say to my team about the green boxes is when we think about the functional areas, like the business side of running healthcare, we don't have to stay inside healthcare to get expertise here. There are people working in every sector of the economy to streamline these parts of running a business, and we should be learning from them. I know that a lot of time we say that healthcare is tricky and it's different, and it is. But I think we need to save that expertise for the things which are our bespoke, our custom healthcare processes, our workflows, but not for like our core operations and our back office. And I've just put a blue box around one because I want to talk about a pilot that we are running in the UK, which I find very hopeful. So many people think that in the NHS, because it's a national health system, that all the data is perfect and it's all interoperable and everybody can see into everyone's data, and if I live in London but go to Manchester and break my leg, it's okay because the ambulance service there will have my full medical record. Sadly, that is not true. The process of aggregating data across the NHS, even though it is a national health service, is in process, but it is far from complete. A pilot that we ran with one region of the country, in Yorkshire, along with Google, gave me a lot of hope. So in Yorkshire, they created a shared care record. They have data in a lot of different places. So GPs are holding their own records, hospitals are holding their own records, social care, mental health, etc. They were able to link these. And then the really smart thing here is the way that AI can help interrogate data, which has not been made to be interoperable, which is sitting in different, some of it is in text, it's in different places. If you think about how, like, we probably all do a Google search every day, and Google queries, the entire internet for us. In my case, this morning, it was like acai near me, and it was very helpful for that. But Google can do the same for our healthcare data. So what we've done in Yorkshire is, if a clinician is sitting with a patient and they want to know, have they ever had in their whole life an interaction to this medication, or I just want to see their diabetic history, or I want to see if they've ever broken any other bones, is this symptomatic? This piece of AI can query that. So I find this hopeful because I think a lot of us this week, I've had a lot of conversations about interoperability and kind of, if you go back to my iceberg slide, the different layers, thinking about the data layers and how kind of quote unquote messy a lot of our healthcare data is. If I think about my email, I'm always trying to rigorously put things into folders so I know where everything is. I mean, the answer here is like, don't organize it. AI can find it for you. So that whole sort of chapter of work that we kind of look at with slight fear and trepidation, perhaps, doesn't in all cases have to happen. So this gave me a lot of hope. It's really great for both the clinicians and the patients in Yorkshire. They're getting a better service. They can see complete data. And that's just one example I wanted to share with you guys today. We're doing so much work in this area, it was hard to pick an example, but I wanted to mention one more quickly. Last year, I mentioned to you the use of a digital assistant, which is a pilot that we're running with the Ottawa hospitals in Canada. And that is actually, this is text, obviously, but that is actually video, and that is an avatar, an AI avatar, which speaks to elderly patients post-surgical discharge and runs through a discharge checklist that a human used to run through with them. And this is a pilot that has gone so well that we're actually looking at digital assistance for other parts of the healthcare value chain. We're looking at assistance on the admin side, on the pharmacy side, and the reason is, the patients loved it so much. In my head, and we all have biases, back to my thought on bias, I thought elderly patients might not like speaking to an avatar. They might prefer to speak to a human. Not true. They loved speaking to the avatar. They spoke to the avatar on average for 30 minutes, and the human conversations were usually less than 10. The avatar got a higher quality of clinical data out of the patients. Have you taken your meds? Have you been to the toilet? All of this checklist information they needed to collect. But they also listened to the people's stories that they wanted to tell them about what was happening in the neighborhood or something on the news, because they have unlimited time, right? Unlike the human who used to call them. And in the feedback scores from the discharged patients afterwards, they also reported higher feelings of well-being, which I think is a really important thing and something not to be scoffed at. This was a finding which has led us to develop the digital assistant further, and again, is, in my view, another great cause for hope when it comes to generative AI, because we don't have enough humans to do all of the healthcare work that we need to do, and where we can augment them and support them with AI, either, invisible AI with text, like in Yorkshire, or with an avatar, like in Canada. We can create a better quality experience for patients. We can start to take away some of the pressures on our healthcare systems, and hopefully start to change some of the news stories that we see around healthcare. So I hope that was a good little sort of taster intro to healthcare. Now I'm going to hand over to Rafael to speak about the SEER project in Portugal. Rafael.
Thank you, everyone. I don't need to take much time introducing myself. I'm an ophthalmologist, so I have two disclosures to begin with. So the first and foremost, I'm not going to talk about generative AI. I'm going to talk about AI because the project that I'm representing uses AI, but generative AI still does not have a place in current clinical applicability in ophthalmology, although there's an enormous amount of research going into it. The second disclosure that I'm going to make, I'm a lonely surgeon. When I talk about health economics and health management, you will think that I'm way over my head, and you will be right. So, what is the problem, first and foremost, that we want to tackle? Well, the problem is blindness. Why? It's incredibly impactful worldwide, and in particular in Europe. There's 10 million people going blind in Europe, and the cost annually is about 50 billion euros. And just to get the numbers a bit lower, the cost of one patient going blind is estimated to be around 30,000 euros. And what are the main thieves of blindness? They're glaucoma and diabetic retinopathy. So now is the part that I'm going to bore you with clinical stuff. So these two are the main irreversible blindness culprits in worldwide, particularly in developed countries. The problem is they are preventable. This is a problem in the sense that society should take an effort to put in place effective screening programs, because if you can prevent, you should diagnose more. Glaucoma in particular, which is what the project that I'm talking about is going to focus on, is incredibly prevalent in people over 50 years of age, and this is a very scary statistic for me as a clinician. More than half of glaucoma patients are undiagnosed. So more than half of patients with glaucoma are roaming around in the streets not knowing that they have a potentially debilitating disease. Well, and this is another scary statistic, a third of patients that present to our clinics already advanced. So those are patients in which preventing blindness is very, very challenging. So let's talk a bit about barriers and bottlenecks that we want to overcome. Let's start with a hospital practice, which is where I come from. Well, to diagnose a glaucoma patient, you need a lot of time, you need a lot of tests, and you need to spend a lot of money. Whereas in the community level, it isn't about that. It is about referral and awareness. And what we see worldwide is that patients are not referred to be screened for glaucoma, they are referred for something else entirely, and we happen to stumble upon glaucoma, and that's how clinical practitioners diagnose glaucoma more often than not. So we want to tackle this. What solution have we devised? Let's not talk about AI for a minute. Let's just talk about screening protocols. So glaucoma as a disease actually meets pretty much all the criteria that WHO has set for an effective screening protocol. It's very common. It has an asymptomatic phase that can be detected. There are treatment measures that we can put in place to prevent negative outcomes. Overall, that's what we want from a disease, to set up a screening protocol. But, for example, the US Preventive Services, I need glasses, I know, made a decision about whether we should a recommendation whether we should screen for glaucoma, and the recommendation was we do not have sufficient evidence to recommend this. And why? One of the reasons was the testing that we need is not available at the primary care setting. It's very expensive, it's very costly, it's very resource heavy because you need technicians to operate it. So the recommendation was do not proceed with screening. So this is when AI takes the place of the traditional diagnostic tests. It's not there to diagnose per se, it's there to screen, to identify those people who are at risk. So what we want to do is use AI to feed it pictures taken from a relatively ordinary camera worldwide. It feeds it a fundus picture of the eye, and the AI algorithm will tell us this patient should be seen, this patient should not be seen. The machine does not say this patient has glaucoma, this patient does not have glaucoma. This patient should be seen, this patient should come back in 2 years or something. And MONA algorithm, which is the algorithm that we've been using, is actually capable of detecting both glaucoma and diabetic retinopathy. So that will be a plus, and I'm not going to get into that. So what we want to do is set up this in every primary care setting, so people over 50 or over 55, depending on the epidemiological studies, can have a picture taken, and that picture can be analyzed, and the patient can get a recommendation. Okay? So now you've just heard me saying we want to set a camera in every primary care setting. That costs a lot. So each one of these cameras is about 40,000 euros or something. Well, in many countries in Europe, and for example in Portugal, these cameras are already there because many countries use them as part of their nationwide protocols for screening diabetic retinopathy, which doesn't use AI. It can, but it doesn't in most cases. But those cameras are already there. So we just can piggyback on pre-existing hardware to take pictures of the patients, and the AI will make the recommendation for us. So one of this barrier or bottleneck that I've spoken about is overcome or ameliorated. So we project that in about 3 minutes, we can take the picture, oh Jesus Christ, we can take a picture, Cristo Redentor, we can take a picture and we can get a questionnaire form filled out, we can get the intraocular pressure, we can do a lot of stuff in 3 minutes and get the patient screened. And importantly, this can be remote, so this can serve underserved areas. So what is the gist of it? So this model, this AI algorithm that's been trained and validated for screening glaucoma and diabetic retinopathy has very good precision. Comparable to a glaucoma specialist. It can, in a single scan, detect multiple diseases, mainly glaucoma and diabetic retinopathy, and it can be scaled and integrated into the primary care setting. As a part of our project, obviously we're going to measure what we're doing, so we need to know what the outcomes are, so the clinical outcomes, the patient-related outcomes, the process outcomes, and obviously the money. Okay, I'm going to talk a bit about later. So what about the implementation of the project that we're taking apart? So these are clinical partners on the left. So we've partnered up with a lot of different sites, different hospitals all around Europe. We've partnered with our industry partner, that's MONA, that's the proprietor of the AI algorithm. And our Swedish friends did the health economics studies, which was why I really wanted to see some Swedes here, but I haven't. So what do we project this will have as an impact on healthcare resources? So we project that we'll be able to screen 3 times more patients with this technology compared to the traditional clinical setting. We project that we can reduce the amount of clinical visits, the visits to the hospital, by around 90% due to glaucoma. My Gmail inbox just is excited with this number. And we project also within around 15 years that we can reduce the costs of healthcare related to glaucoma by about 10 times. So it's 4 million against 40 million. That's a big number right there. So what about cost effectiveness of this program? How much do we need to spend initially, and when are we going to need see our returns? So we project that in about 3 years we can get this to break even. And our partners in Uppsala did the studies using different willingness to pay figures, different qualities, and projected that in developed countries the time to break even would be between 3 and 8 years in most countries. What about the impact on society? Remember our objective, we want to prevent blindness. So we project that by detecting cases earlier and treating them earlier, we'll be halving the risk of going blind due to glaucoma in about 15 years. So each one of those patients not going blind let's forget about the clinical outcome there, which is enormous. It's going to save us about $30,000 to a healthcare system, euros actually. What about the social and economic impact? Who are we targeting in Europe if this gets scaled up? So there's about 150 million people in Europe with more than 50 years of age. So these are the people we're targeting, and we project that this project will newly diagnosed patients, around 10,000 patients, and will save about 1,500 people from going blind. Now I'm just going to talk about the interim results from our pilot that started around 11 months ago. So we started to call upon patients from the local Lisbon area to come and get screened. We contacted about 1,000 patients, and about a third came. If you've ever worked in a voluntary screening protocol, this is an excellent figure for a voluntary screening protocol. A 2/3 response rate is very good. And we screened 671 patients, and 82 were positive. So in 82 cases, the machine or the pressure that we measured, because intraocular pressure is something that we measure in patients who are at risk for developing glaucoma, because most patients have elevated intraocular pressure, 82 were positive. So these 82 were contacted again to come to the hospital to do the tests that are going to be diagnostic or exclusory. So 72 attended, and about half of the patients that were initially positive were actually diagnosed with glaucoma or glaucoma suspect, which is a milder form or a form at risk. So, just to highlight one thing, only 20 patients of those who had screened positive had a clinical sign that we usually see every patient. So we think intraocular pressure is key for those doctors that are there. We've always heard about intraocular pressure in glaucoma. Oh, I need to get my pressure checked and so on. A minority of patients have had intraocular pressure. The machine identified patients who conceivably would never get referred for this kind of disease. My time is running out. I'm just going to show you something. This looks a bit iffy, but you see the big bars on the right. Those are the amount of patients who presented with mild disease. So we picked up 80% of patients had mild disease. Still, 20% of patients had moderate to advanced. So we're still not getting early enough. So to sum up, our experience so far, a 2/3 response rate, which is very good, it's very encouraging. This has a low investment in our setting because it's synergic with the pre-existing DR screening protocol, and in high-income societies, it breaks even within 3 to 8 years. Thank you so much for your attention.
Thank you, Rafael. That's brilliant. We're now going to hear from Professor Aymeric Lim on deploying AI in healthcare, transforming hospital solutions. Professor.
Good morning. My brief is to present the deployment of AI initiatives from a hospital perspective. So it's operational, and I hope to give you an accurate picture of what's actually happening on the ground in the hospital in which I work. So I come from Singapore, and it's a tiny country. It's half the size of Rio with 1/3 of the population. And it does make management of healthcare a lot easier. So Singapore does have good healthcare outcomes. We spend a relatively low proportion of our GDP on healthcare, and we have a good life expectancy. What are the factors that contribute to this lower cost? I think that we are quite pragmatic in the way that we approach healthcare. And I've given 2 quotes here from the founding father of Singapore, Lee Kuan Yew. And basically, number one is personal responsibility. So there are 2 aspects here. Every patient is personally responsible for their own health. And 2, whatever healthcare that they consume, that they should pay a little bit. Even if it's $1 or $5, every patient has to have skin in the game. And we found that these principles have carried us well so far. Our healthcare system is divided into 3 regional health systems that cover the whole island. And the one which I'm representing today is the National University Health System. It's the one in blue. which covers the western sector of the island, about 1.1 million patients. It's an academic health system and covers the full spectrum of healthcare facilities. So we have our primary healthcare, which we call polyclinics, and all the way to the acute hospitals. The National University Hospital is the tertiary hospital in the system, and we're especially proud that in our system that we have one of the top medical schools and top nursing schools in Asia. So we're a tertiary hospital, we're a major referral center, and we have flagship transplant programs, quite busy, about 1 million patients a year for about 1,200 beds. We face the same challenges that any small developed nation faces, and I've divided them, the many frames, I've divided them into access challenges, which we have a rapidly aging population, one of the fastest in the world. There are economic barriers for segments of our population, and we have acute workforce shortages because of our small population that's aging. Overlapping a lot with access issues are cost issues, so of course you have the rising costs, there's financial burden on patients which gets passed down, and we have to deal with rising patient expectations. In terms of quality, these are very much the same: variation in care, medical errors, and coordination of care. AI can address all these challenges, and this is our staff and patient-facing platforms. And here we have 3 chatbots, 3 LLMs. One is called Russell, named after Bertrand Russell, and this is for the clinicians. The second one is one that's specifically for administrators, so we find that quite useful. And that's called Bot NUHS, and we have one which exists at national level, which is called Tandem, and it's like a national chat GPT. You'll see that many of our constraints are based on the fact that in Singapore, our data has to be housed in Singapore. We do not allow transfer or storage of any of our patient data overseas. So access. How does AI increase access to healthcare? Well, I think number one is it mitigates the manpower shortages and makes the jobs of our healthcare workers much easier. It also helps us to allocate resources. And of course, there's telemedicine, there's information databases, and I'm going to give for each of these categories 1 or 2 examples that we're already deployed in our hospital. So for workforce shortages, we use the LLM that's designed for clinicians, and that's, we call it, as I mentioned, Russell GPT. And what's here, so we have MediVoice, which is a voice-to-text app. There's what we call medical record office, so when doctors need to write medical reports, it generates them from from our electronic medical record. And it also summarizes case notes and consultations. This is already present in many of the electronic health records, but in Singapore, like I mentioned, we have constraints with our databases. So some of the things that are available, say on Epic, are not available for us, so we had to do this. What is special here is that Singapore is a diverse country. People speak 3 or 4 languages, and MediVoice is able to understand Chinese and English, and Malay and English, and bring them into a summarized English summary. So that's helpful. For our hospital operations, we do have large projects, and we want to span the spectrum of inpatient care. So we have an emergency department predictive dashboard, which predicts surges in the emergency department, and which is starting to help us to plan for shifts and deployment of manpower at the right time. We have an estimated length of stay model, which I found quite interesting. So when patients come in, you get an estimated length of stay. And one thing which the LLM did is that it looks for social on the patient's records. And the more you see social, the longer the patient's length of stay is going to be. There's a 30-day readmission prediction model. And there's a chronic disease chatbot system which monitors patients' records. And if there are flags in the blood results or anything, it engages the patients through the chatbot. And the thing that we have for access is the NUHS app. So this is a master app that spans patient. So a patient has a query, they speak to a chatbot, then they can arrange an appointment, then when they come in, they are registered, they have access to the blood results, and after that, we can also do a telehealth consult. After that, they are reminded to pay. They can pay on the chatbot, and there is follow-up. So it covers the whole gamut and has helped patient access immensely. It's been very good for the hospital operations too, and we've seen great manpower efficiencies there also. So for cost, like I said, these overlap a lot with access. The rising cost of healthcare, AI can help us, is helping us to reduce healthcare. I mentioned the chatbot, the NUHS app just now. And I want to show this, how we've constructed our administrative LLM. And so we have a number of categories that range from the drafting of contract to accessing our protocols, to accessing our policies, to engaging patients. So for our administrators, they go direct to this LLM, and they type in their queries, and whatever is relevant comes out, which helps them in their work. We also have another application, and this is an efficiency thing. Our doctors often give multiple orders for the same scan, so MRIs or CT scans. And these come into the system and choke up the system. Patients are given multiple appointments, and sometimes, so the machines either there's wastage of use of the machines and wastage of the use of patients' time. So what this application did was it trawls all our investigations, sifts out the ones which are duplicate, and we've saved about 90% in that. It's a small application, but it makes a big difference on the ground. And finally, under this category, we have community care, and people have to go to different places. So this Dr. Anthony helps plan routes for the home visits. Quality, we are experimenting with this. So this is a bot that helps on our cancer tumor boards. And it's fed specifically with our cancer data, historical data, and it helps in decision making. So here you see that having specific feeding helps it to be more accurate. And there are other applications in education. So that comes to what we've deployed and are deploying, but we're very cognizant of the risks of AI in healthcare, especially for clinical safety. We cannot afford to allow any mistakes. And because of this, our capabilities were planned 10 years ago, and we have structured for safety and governance. So this is a diagram of what we have, and at the bottom is our data warehouse, which is organic to our system, NUHS. And to construct that took 3 years, and we had to pull in all the data from all the departments, surgical, medical, and all that. And this is interrogated by 2 other platforms. One's called Discovery AI, which is historical, which is based on historical data. And the next one is Endeavor, both are named after Challenger space shuttles, after space shuttles. And the second one provides real data and real decision making, in real time, sorry. So our governance, the same principles as anywhere, but specific to us, I would say, to me, the most important line in all that we do is that the clinician is ultimately legally responsible for the patient's care and health outcomes. That's it. That's the bottom line for us. Along that, we don't want to be too strict, and we want to help to develop, so we're proactive in being efficient. Our key governance measures, apart from the structure of our database, is proactive governance committees of clinicians that closely follow the deployment of each AI project that we roll out. So where are we now? And we did a survey in June 24, and we're actually quite disappointed to see that of 116 reported use cases, only 14 were in production. So there was a problem of, well, I would say, deployment and also people actually using our AI initiatives. So that's something that we are working on. I would say our lessons learned from implementation are data infrastructure is the foundation. Implementation requires organizational trust, and we have committees, as I mentioned, for constant human oversight into whatever we roll out. The future, it's a hard one. This AI revolution is probably one of the most significant of I think, human existence. And the main question at societal level is, will society be able to adapt to everything that AI does? And back at the hospital level, AI will transform healthcare, has transformed healthcare, but this deployment needs to be balanced with proactive governance. Thank you.
Thank you, Professor Lim. And now we'll hear from Michael Schlosser from HCA, who will take us up to the system level.
Excellent, thank you. Excuse me, and thanks to the IHF for inviting us back to reprise this panel from last time. I'm with HCA Healthcare. We're the largest healthcare system in the United States. We have about 186 hospitals, 2,400 other sites of care, including urgent care centers, freestanding emergency rooms, physician clinics, and we have the privilege of taking care of about 43 million patients a year across the 20 states that we operate in. So I'm going to focus my time here talking about scale, and I think actually this was teed up very nicely. That gap between the hundreds of use cases and the ones that actually end up in production being used every day to drive value in healthcare, because ultimately it's really interesting to talk about AI algorithms and to train them and to see what they can do well and what they can't, and study them and publish on them. But if we're really, if we're really going to transform healthcare, if we're really going to see a different outcome for patients in a meaningful, measurable way, ultimately we need the applications to be scaled, and we need them to be rigorously adopted and studied. And so I'm going to give you 4 things to think about as I go through a little bit of HCA's strategy when it comes to scaling artificial intelligence. The first one, which will probably seem sort of obvious, but I think is actually incredibly important, is to have a very clear vision of what it is that you're trying to accomplish. Another thing I think you would take away from even just this panel and probably your time here in Rio over the last several days is that there are dozens and dozens, if not hundreds, of different interesting AI applications out there. And so what do we decide to focus on, and what do we prioritize? And if we don't prioritize, we're just sort of spreading that capability very thin across lots of different opportunities, and we probably won't get the depth and the penetration and the value that we're looking for. So having a very clearly defined vision and strategy of what we're trying to accomplish, I think is critically important. The second one is to really involve the end users directly in the development of the application. So in order for things to get adopted and for us to measure value, they have to be used. And we have found, and I'll show you some examples of this, that the only way to really do that successfully is to directly involve the end users, and not just an advisory panel that gives you some feedback, but really iterative design where we're constantly improving the product as the users engage with it, and that is an ongoing process that really probably exists for the life cycle of those products as they're being deployed across a healthcare system. The third thing that I think is critically important is measurement. And we do this really well in healthcare when it comes to clinical science, and Rafael showed some great examples of this where we're very specific about the diagnosis and what percentage of patients and how many moved on to the next phase and how many got treated and how many got better. But in healthcare operations, when we're talking about how do we make healthcare delivery more efficient and more effective, especially at a system level, I think we tend to fall off a little bit. And so I'll show you some examples in my presentation of what I mean by really rigorously measuring the impact that a system has as it's deployed, an AI application. And now I'm going to forget what the fourth one was that I wanted to leave you with. So I'll come back to it as we get into the presentation. So I'll start where I started, which is with the vision that HCA Healthcare has for what we're going to do with generative AI and with digital transformation in general. So We really find ourselves, I think, at an incredibly interesting time in healthcare delivery. In fact, I think a time like there's never been in the history of healthcare coming before us. And I see really three macros that have created this opportunity, and the reason why HCA Healthcare, at least, has decided to seize on this opportunity. There was a moment of change coming out of the pandemic, and it was palpable to us that there was this impetus to get better, that we've constantly wanted to improve healthcare, we've wanted technology to deliver better outcomes for our patients, but it's been sort of a slow and methodical process, and I feel like the pandemic really lit a spark that made us feel like the time is now and we have to change. The second was the advent of big data, and at HCA Healthcare, I've shared with you the size of our organization. We've been collecting data for a couple of decades, but in the past, with systems like Teradata and on-prem infrastructure, it was actually challenging and expensive really to leverage big data in healthcare. And the data is very messy. Coming out of an electronic health record, a lot of unstructured data, even the structured data can be captured in different ways. And so we would find that we were spending 80% of our time doing things like organizing and standardizing and determining the quality of data, and only 20% of our time actually making use of the data. Now that has really flipped, and cloud computing makes it incredibly easy and inexpensive to store all of the data, and we can get very greedy when it comes to data now and say we want every single data point that a bed or a bedside monitor or an anesthesia machine can stream, and we can collect it in a data lake, and even if we're not going to use it right now, we can store it at relatively low cost for the future. So the power of data systems has really changed things for us. And then the third macro force that I think really led us to where we are today is artificial intelligence. And it sort of showed up just in time as we were getting ready to make these changes, and in particular generative AI. And while that grabs all the headlines, I think generative AI really has created the excitement, but there's lots of other artificial intelligence that's really coming to bear. And so we find ourselves with an unprecedented ability to care for one another that we really have to take advantage of. And as I mentioned, the voice of the caregivers, and really, yes, that's incredibly important when we're developing solutions, but I think there's also an opportunity for us to level up our clinicians. The clinician of the future is going to have to be data savvy. They're going to have to understand artificial intelligence and machine learning, at least at a basic level, so they can engage with these systems in a meaningful way. And that's an amazing opportunity for us to develop our workforce into this workforce of the future. It's often said that AI is not going to replace doctors and nurses, but doctors and nurses that know how to use AI will replace those that don't. So I mentioned we have a myriad of opportunities that we can choose to focus on. Healthcare still remains very manual and fragmented, and it grew up organically. The way we deliver care was sort of learned by every clinician, and they all practice it a little bit differently. And so there's a ton of opportunities to focus on. And what HCA Healthcare has chosen to focus on is, at least in our initial phase, is administrative burden. How do we take away all of those extra steps and extra processes that we've put in place, a lot of which came through the EHR, for our clinicians who really want to spend their time focused on patients, providing physical and emotional support to those patients. And we believe that if we give the clinicians time back and give them better access to data and insights, that we can level up the entire healthcare system. We can give them the time to think critically, to support patients, to make better decisions, to ensure patients follow up with the next step of their care. We don't need to sort of jump over the clinician and try to have AI solve those problems. If we solve problems that the clinicians identify and give them that time back, we can help them do their job better. And lastly, before I jump into the use case that I want to spend my last few minutes talking about, this is something that's going to have to come from inside the healthcare system. So other external entities like big technology companies, small technology companies, startups have tried to solve healthcare. They've tried to disrupt healthcare, and it hasn't happened. I mean, they've really failed to make meaningful change. And so we believe it's going to be the healthcare systems themselves in radical partnership with these tech companies. Oh, and that was the fourth thing, and I remembered. The fourth thing was partnerships, that we're going to have to partner directly with these companies that develop these solutions and co-develop this future that we want to create. So the use case I'm going to talk about, and I'm going to show you a video here in a second, that I think is a great example of how we're thinking about scaling solutions, is nurse handoff. So in our hospitals, the nurses hand off their patients from one shift to the next about 400,000 times every week, so roughly 21 million times a year. And so it's an incredibly important part of care delivery. We have to make sure that nothing is dropped, that nothing is missed. It's also, honestly, an expensive part of care delivery. We're paying 2 nurses at the same time to care for that patient. If you do the quick math of 2 nurses, takes them about 45 minutes to do the handoff. We do it 400,000 times a week. Nurses make about $40 an hour in the United States. So we spend about $500 million, $500 million a year on handoff. So this is a great use case. It's a great scaled opportunity where we can solve a clinical problem. This is a problem the nurses would identify themselves. They hate this process. It's very manual. You're going to hear about that in a second in a video. And there's a great financial return potentially, which then can fund additional innovation in the future.
Technology has improved many aspects of healthcare. Still, more potential remains to support caregivers and the best possible outcomes for patients. How can technology ease the burden on healthcare workers and improve patient care? HCA Healthcare is partnering with Google Cloud to leverage technology to do just that with nurse handoff. This is when a report is handed at shift change from one nurse to the next to facilitate accurate and expedited exchange of critical patient information from multiple sources. It's a time-intensive manual process.
As nursing, what we'll do before we give report, we'll go and dig through the chart and make sure that we add relevant information to the next shift.
That process, a critical exchange of patient information, is repeated 60,000 times daily across HCA healthcare facilities. Elevating the nurse's voice through direct feedback, HCA Healthcare and Google Cloud are developing a tool to help make nurse handoffs more seamless.
Every team's involvement in making this project a successful project was key, where you have technology working with clinicians, working with change management, education, our nurses and physicians, all coming together and building this product at the end of the day.
The nurse handoff solution took shape in just months, moving quickly from ideation to proof of concept. The large language models are trained to faithfully distill the most contextually relevant data identified by nurses to ensure all details are included in the report for seamless bedside care operation.
For the future of healthcare with Google Cloud and HCA Healthcare, it gives us the opportunity to edit in real time. It gives us the opportunity to help that oncoming nurse and to make adjustments right there at bedside shift report. It allows that nurse to see what's happening at that moment in time.
This new report is definitely going to be used as a resource for nurses. It's not meant to be a replacement. It's so that we can do our jobs better, and most importantly, we can spend more time with our patient and do all the patient care that we love to do, that we came into nursing for.
With HCA Healthcare's thoughtful approach to responsible AI, clinicians' input plays a key role in the continued evolution of the nurse handoff solution, serving as the human in the loop.
The technology makes it more efficient for us to give back to our patients, to bring in a better smiling face. It makes us feel good as nurses to know that we're listened to. That way we can give that hope and care back to our patients.
So I'll run over my time, but I'm just going to spend one more minute sort of summarizing. And this slide really just shows you sort of the depth of the integration between the frontline caregivers, our data scientists, Google, and all of those who came together to build this solution. And this is what I want to leave you with, which is when we started this project, we started with sort of out-of-the-box large language models. We tried Llama and GPT-4 and Gemini Pro. And when we rigorously studied and evaluated the quality of the output, when we asked those models to create a shift summary, a handoff tool, it was actually pretty low. And if you can see that the initial values in V1 and then how much they improved when we got to our V4 of the tool were actually pretty dramatically different. And so this ended up being probably the most important part of the entire project, was getting really specific on these 5 metrics. So is the output of the model factual? Do you have the right coverage? Is it missing any critical information? Is it concise, and is it contextual? Is it putting the information together in a way that's easy to consume? And then lastly, is it helpful? And so we would provide the model to the nurses. They would rate the output. You could see it in the video. They can do it right there in the tool. They can rate it against these 5 metrics. That data would then annotate the data. We would go back to the Google research team and we would change the prompts, we would change the RAG technology, and then we would give them another version of the tool. And we kept doing that until we got these numbers to the point where the nurses were really telling us, this is helpful. 90% of them said that they can replace what they're currently doing, which is a very manual and laborious process, with the output of this large language model. And that told us that we were at the point where we're ready to actually bring this to scale. And so we're in the process right now of building the scaled architecture to bring this to those 400,000 shift change that occur every week in our hospital. And so the message I would leave you with, again, I'll go back to those 4 things, is you have to have a clear vision. And I think you can see with HCA Healthcare and with the comments from our nursing staff, we're in that video, what it is that we're trying to solve for. We need those tight partnerships, in this case with the Google Cloud and Google Research team, to bring their expertise and our expertise together to solve these problems. You need that voice of the end user. If these folks are going to change the way they care for patients, which is something they care deeply about and worry about, you have to involve them in a very deep way in the way the solution is developed. And then lastly, you need to measure and to really know that this isn't just a tool that they're going to look at and tell you, wow, that's really cool, and then they're end up putting it down because it really isn't helpful to them. You have to rigorously study and evaluate and make sure that you're actually creating the outcome that you're looking for. So I'm running out of time, so I'll end there. Thank you.
Brilliant. So thank you all. Those were 3 incredible presentations. I'll kick off the questions, and I'll just remind the audience that you can put questions in the app. I am seeing your questions. And you can vote on the questions you like the most. It still doesn't mean I'll ask them, but I might. I'd just like to kick off with a bit of a follow-up question for all 3 of you. Professor Lim, you spoke at the end about how ultimately the clinician is still responsible. Michael just spoke a lot about nurse handover, and obviously the SEER project involves, clinicians as well. Maybe we'll start with Professor Lim. Can you just talk a little bit about how are clinicians feeling about these tools, and what are some of the maybe promising signs or challenges that you're seeing with clinician adoption?
Well, most of the tools that we've rolled out have been to help them be more efficient. Mm-hmm. So they're feeling quite positive about it. I presented one example of a decision aiding model, the one for our tumor board. And for there, we haven't deployed it yet. We're still studying it. There's one tool which I've been trying to push out for a long time, and I hope there are no radiologists in the audience, but that's, I think there are more than 700 FDA-approved AI use cases for radiology. So one just to read chest X-rays or CT scans, and that one, there's a lot of resistance, but I've been promised it'll be rolled out next year. And the efficiency would be that instead of having 2 radiologists read a chest X-ray or CT scan, you just have to have 1. The AI screening, and then after that, the final read by a physician.
Amazing. Michael, are nurses excited about this opportunity, by and large?
I think an honest assessment would be that the clinicians are all actually pretty fearful about our AI. I think when you talk to them, now the ones that are directly involved with the work, I think, have become champions and advocates for it. But in general, I think there's a lot of trepidation about what is this going to mean? Is it going to replace me? Is it going to make my job just harder to do, like EHRs? If you remember when we started rolling out EHRs, there was all this promise that this was going to make healthcare better, and it turned into just a ton of work for the frontline clinicians. And so there's definitely some fear around that. But I think there's also excitement. I think they see the potential, they see the opportunities, and so we just got to seize on that potential. We got to seize that excitement and really run with that and continue to get people engaged. Change management is by far the hardest part of this entire thing. And so, again, a lot of the reason why we have built that handoff tool the way we have And part of it is so that it would be successful and it would be useful, but it's also to overcome that change barrier, that the nurses are much more likely to use the tool and engage with it if they know that it's been designed by their colleagues with sort of the way they think and their workflows in mind. And so I can't stress enough how important focusing on change management from the very beginning really is going to be for us to be successful with AI. As interesting and excited as folks may be, at least a subset of them, when it comes to you actually having to change the way you do your job, and again, especially if you're a clinician who has a patient's life in your hand, you're going to be resistant because you want to make sure that the pathway forward is safe. And so I think that's the most challenging piece of this whole thing.
Thank you. Rafael, anything to add?
Well, in terms of acceptability, it depends a lot on what the task that the AI algorithm or solution is designed for. If we're talking about removing admin work, I think every doctor gets excited. If we're talking about changing the way that clinical decisions get made, then the resistance comes. I'll give you an example. Every patient that gets screened with our pilot program, every patient that gets a negative result, so the machine doesn't beep, the patient gets sent a letter signed by our head of glaucoma department saying, you, through this tool, do not seem to have an apparent risk, please come back. That is a clinical decision that is very remote from the patient. The patient has not been seen by a doctor, and we're just using a tool to get that clinical recommendation in. So I am sure that there are many doctors out there that look at this example and frown at this example because it's difficult to stomach this separation from the patient-doctor decision. So that's one of the key barriers for acceptability, I think.
I want to comment, though, on the reducing administrative burden and people being excited about that, because while I agree, if you sit in a room like this and say, hey, we're going to deploy tools that will reduce administrative burden, all the doctors would, they would cheer for you. And then when you go to them and say, okay, here's your new AI app that you're going to use to do documentation, and you have to do it this way because the AI needs to hear you, and so you have to annotate your care a little bit more, the excitement goes away because they've come up with sometimes not great workarounds. Sometimes, the outcome of that documentation they're doing isn't terrific because they found shortcuts through their process, but it's working for them in their current state. And so, again, I'll just go back to really thinking through how do we get them through that change so that we can get them to what will be a better solution. And they would agree it's better, but it doesn't matter how much better it is, the change still can be challenging.
Definitely. I know that we built a tool which took a GP's letter that was for referral to secondary care, and it automatically triaged it, and it made a decision. This needs to go into a 2-week cancer rate, this needs a diagnostic test. And at first the clinicians hated it because it was a black box. And then when we, to a point that you made, Professor Lim, put the human back in the loop, used them to help us train, showed the comparison to the manual referrals that were being done. And then when they can make their own decisions to accept or reject, which I imagine is what you're also doing in Singapore, since the clinician is ultimately responsible, then we got huge buy-in. So I think it goes back to your point about just needing to tweak it and figure out what the right balance is. Okay, so on the positive side, what is the most exciting thing that you see coming down the track when it comes to generative AI in healthcare? So far today, we've talked about the things that we're testing and beginning to use in anger. If you look a little farther out, what really puts a sparkle in your eye? Maybe Professor Lim, can we start with you again?
Well, as a practicing hand surgeon, I would say it's reducing the administrative burden.
Okay.
The next would be predictive analytics.
I'd say disease risk prediction.
Yeah.
So tailoring disease risk prediction and tailoring screening protocols and hospital visits for patients who are at risk.
Yeah, great.
I'm going to have to cheat and give you two. One, I would agree, obviously we're very excited about reducing administrative burden, and when we look a few years down the road, and I don't actually think it's that far, the idea that you could have an AI agent, or it's probably a team of agents, in your pocket on your phone that can sort of just be your assistant as a physician or as a nurse to sort of do all the things that right now it's hard to do. Search for information, find data, send messages, collate information that's coming in, prioritize alerts as they occur. the idea that you could have just like your own personal AI that just helps you get all of that work done so that you can focus on the patients, I think is going to be incredibly powerful. And there's lots of folks, I know you mentioned that Deloitte is working on virtual assistants as well, but I think that's incredibly exciting. The other side for me is really advanced decision support capabilities. So I do think predictive analytics are interesting, but we're not trained yet as physicians to know how to treat predictions. Like, so how do I treat a condition that the patient doesn't have yet? In some cases, it might be straightforward, but in many cases, it isn't. But so I think what's going to be really interesting is AI's ability to collate all the data in real time on a patient and help you understand exactly what that current state of that patient is and what the best option for treatment is going forward. And so we're working on a project partnered with GE, getting back to the partnerships, doing this in the labor and delivery space. When a mom is delivering a baby, there's lots and lots of different sources of data, the fetal heart monitor, but many others that all come together to tell you, is that event going well or is it not going well, and do you need to change course? And the idea that we could bring all of that information and the care team together onto a single AI-powered platform so that they all have the same information, the same insights, and can make good real-time decisions, I think is going to be game-changing, especially for hospital care.
Great answers. So looking at the downside, many of you, including myself, talked a little bit about the risks. What is kind of doomsday scenario might be a little heavy, but what is a downside risk that you foresee is potential or probable, and what could we do about it? Rafael, do you want to start?
Well, in my field, or the field of clinical medicine as a whole, I would say misdiagnosis. I would say a replacement of a function that may be comparable in research settings, but the leap from the research from the clinical applicability is not done carefully or is rushed because everyone wants to get on this boat in AI, and then people are removed from a healthcare setting or the loop of healthcare because AI has replaced this or that function, and then we get misdiagnosis or false negatives and so on. That's my doomsday. That's what I fear, that some of the people that I've screened have come back home. I know they're going to come back, but they might not want to, and they have a disease that I have not detected because I'm so confident in my AI.
Yeah, that's a good one. Anyone else?
I think for us, patient data is sacred. It's part of the being of a patient. So I think for us, the biggest risk is compromise of patient data, and that would be a disaster. And we're still working on IT systems that, no matter how safe you make them, have vulnerabilities, and that's our main worry.
Yeah.
Well, it's hard to argue with security and privacy as a huge risk. I think that is one thing that could really pour cold water on this entire thing is if we can't manage the security and risk appropriately. But Sarah, you mentioned in your intro that you're an optimist, and I'm an eternal optimist myself. And so the doomsday scenario I worry about is that we miss this opportunity, that healthcare can't get out of its own way. We can't get our data right. We can't get security right. We can't figure out how to transform the processes to really get AI, into the workflow in a way that creates value. And this ends up just being sort of another layer of technology sitting on top of all of our current broken ways of doing things. And we miss this amazing transformative capability.
Great. We've talked a lot about how Gen AI can help us in the clinical setting. Obviously, the other part of the equation is the patients, the caregivers. Can you give me some thoughts about how Gen AI can change their experiences for the better?
Well, we've incorporated chatbots into our patient-facing app, and I think you mentioned they actually like speaking to the chatbot.
I love it, yeah.
And it helps to triage. And after that, seamlessly they get appointments. So patients, and we've seen also examples that when the AI writes the memo to the patient or to the doctor, they're more polite and more compassionate than when real doctors do it. And I think that part's very positive.
Yeah, I would agree. The chatbots also have infinite patience. Like, you can ask it 1,000 questions and it never gets tired or bored of answering, which is really an amazing superpower when it comes to the patient-facing. But for the clinicians, I think generative AI really is the ultimate user interface. It's really never been sort of it was sort of a round peg in a square hole when we tried to make clinicians work on these very structured EHRs and all of the other tools we make them use, because that's not the way we think and we communicate. And generative AI communicates just like we do. So the idea that you can just talk to the bot and then it can sort of sort out all of those details and structure in the background, I think is going to make clinicians' lives, dramatically better if we deploy it in that way. And they're actually, like, I think, fun to interact with. Like, the chatbots are interesting, and they can answer difficult questions. And so I think it could really bring some of the joy back in giving care, if rather than like hammering away on a keyboard, you can just talk to your AI agent to help you get your work done.
I'd say that the use of these chatbots or any other visual platform could be used very, very effectively for patient education as well, and patient awareness. So improving education in health would be paramount to improving healthcare delivery as a whole.
Yeah. I was speaking to the leaders of the Albert Einstein Hospital in Sao Paulo, and they're using AI in a lot of ways, as are you all. And one of the things that they were using for their own management was an A&E wait time or an ER wait time predictor. And I said, this is so great. This helps you plan, intake, bed management, et cetera. And then as a citizen, I thought, do you share this, with people who are coming in, to the ER, because they might have a choice of where to go. And, they weren't doing that yet. But I think there's patient applications, for a lot of the tools that we're using for hospital management as well. Okay, I'm going to pivot to some audience questions. There's a very popular question that you've triggered, Michael, about how outsiders are missing the mark. But the questioner makes the very good point that there are hundreds of startups working on healthcare challenges and piloting with hospitals. Do you feel there'll be a fragmentation of which technologies hospitals use in the future? And also, this is a good build, how are hospitals supposed to differentiate? Will this be a point of differentiation?
Yeah, no, that's a great question. And I don't mean to imply when I say that outsiders have missed a mark that we're not interested in startup companies or outsiders. We're working with lots of different technology companies. What I just mean is that I think the attempts for them to disrupt us from the outside, as opposed to working with us to transform, have not been successful. It's going to be the partnership where we work together. So there are a couple of risks there that you called out in that question. One is that fragmentation. And so I think point solutions are going to be a real challenge for a healthcare system. There's lots of great ideas out there that turn into sort of a single product company, but it's very hard as a system to deploy those. We actually just launched into an initiative in our own system to try to get a handle on our third-party applications, and we discovered that we had 8,000 different third-party applications running around our health system, and that is an absolute nightmare for IT and for security. Managing that and integrating and organizing and keeping the data secure is incredibly challenging. And so this move to platforms where we have single or maybe 2 or 3 different technology platforms, and then we deploy algorithms inside those platforms and more of a single sort of end user experience where all that information is surfaced, I think is the direction we're going in. So I think the startups are going to have to figure out how do you work inside an ecosystem where, probably being the 8,001 application is not going to be successful. Instead, you've got to figure out how to integrate into the applications that already exist. And then the second piece of it is really that partnership. There's tons of great ideas, but all of those great ideas, at least in my experience, do not survive first contact with the real world, where you put it in the hands of a clinician and the nurse, and they'll tell you initially, oh, that's really cool, and then they'll put it down and go back to the way that they know how to do things, to take care of patients. And so you just have to be flexible and adaptable. It doesn't mean the idea was good. It means probably the interface or the workflow or some other part of the process needs to be iterated on. And go back to the video, that sort of constant iteration process of showing the output, giving the feedback, adjusting, rinse and repeat until you really get those metrics to the point where it's showing you this is going to be transformative. This is going to meet the mark. And so I'm not here to dissuade those in the startup world, but just to say, you're going to maybe have to have a little more patience and be a little more willing to work with those end users to adapt your solution.
Great. Does anyone want to build on that? I'm sure you're working with partners in Singapore, Dr. Lim.
Yes, and it is a problem well, we haven't reached that stage yet, but we are wary of having too many applications coming on and accommodating them into our system.
Yeah, okay. This is a great question from the audience, and I don't know the answer, and I don't know if any of you do either, but do any of you know of examples of how AI is being used for mental health?
Yeah, so a couple of interesting applications that I've seen very recently. One, and I won't remember the name of the company, which is probably fine, was an AI model that could actually listen to the voice patterns of patients and detect signs of underlying behavioral health conditions like depression, anxiety, suicidality. And so this was actually focused not just specifically on mental health or behavioral health patients, but on how can you use that data source, which is literally just the conversation you're having with a patient, to potentially detect those undiagnosed or potentially undertreated behavioral health conditions. And then the second one, maybe just more mundane, was just using chatbots as sort of adjunct to therapy. And this is another area where if you've played with ChatGPT, they're actually relatively good at. You wouldn't want to, turn decision making. You're not going to ask ChatGPT what medication you should be on for your depression, but they're actually pretty good at just helping people talk through and do cognitive reframing around what's causing them anxiety or depression. And so I've seen several pilots of using large language models as an adjunct to therapy that look promising.
Amazing. One for Rafael. Can you tell the audience a little more about the strategy of attracting patients even when they have no symptoms? How do you get them to come in?
It depends on the setting that we're talking about. So patients in Portugal are pretty much open to go anywhere they are called to. Yeah. So they just see it as an opportunity to get free healthcare, which is free in the whole country. So when you contacted patients told them that we wanted to screen for a disease, they're used to doing it at this age group, for the colonoscopies, for the prostate exams, for mammographies and stuff. So they're kind of used to this routine, so the response was relatively easy. It didn't take much to convince them. Still, only 2/3 came.
Yeah, that's true. Yeah. That's true. Well, we're running out of time for questions. There are a lot of great questions in here. I would say a lot of these questions are specific to some of the examples that I and the panelists gave. I would say for these questions, at least for me, and I'm sure you'll agree, please reach out directly to me. I'd be happy to talk about the underlying data models and the interoperability and all of these detailed questions that you've put in the chat. I think it's great that it's spurred so much interest. So now, for those of you who were here last year, you'll know that we like to close with a lightning round. So the rules are, everyone has to answer the question. We start like this and we come back like this. So question 1, Rafael starts. Question 2, Michael starts. You have to answer with one word. You can't do it in a word. You can use a phrase. If you can't do it in a phrase, you can use a whole sentence, but like tight, right? And we're going to go fast. So it's the first thing that comes to your head. Okay, Rafael, what is the biggest development that you've seen in health AI since last year?
Jesus Christ was not the word that I was looking for. So vision transformers.
Dr. Lim.
More and more people using ChatGPT and other LLMs.
Great. Michael.
I'd say virtual agents.
Okay, most surprising application for AI in health, Michael. I don't give them the questions in advance.
Yeah, she's surprised us with these. I would say AI agents providing emotional support for seniors.
Amazing.
Can I skip that one?
Okay, pass, okay.
Oh, me, yeah. So one of the proposals that Dr. Lim talked about, so predicting ER time.
Predicting
period.
ER time.
Yeah.
Okay, now you're really gonna hate me. If AI were a healthcare superhero, what powers would it have? Rafael.
Precognition.
Yes, great.
Omniscience.
Omniscience.
All seeing, all knowing.
Amazing. Thanks for being game, and please thank our amazing panelists. I would try to wrap up our discussion, but I mean, there's just been so much here. I thought that the 3 opening presentations were absolutely incredible. I thought that the glaucoma example really showed us how generative AI can both save on cost and improve quality at the same time. I thought the chart you showed with what can happen in a few years with diagnosis was incredibly powerful. I loved the widespread use of AI in your hospital, Dr. Lim, and I thought the most important point you made was about the clinician in the loop, because that will be the only way that we get widespread adoption, which was a point that Michael also made. And I think, Michael knows from the number of hospitals that his organization runs just how big that admin burden can be, and that too is where I think we will see the absolute biggest bang for our buck. So we are going to a coffee break now, but please thank our panelists one more time. Thank you all.